I want to thank Craig Walker and Arthur Lee and the NCVH crew and team for inviting me this year to give this talk. I'm going to talk about below ankle interventions and pedal loop interventional techniques. These are my disclosures. So when we deal with CLI, these are the types of patients you see. This is a typical week for me, and these are pre and post images of patients I've treated who had CLI. And obviously we all want to achieve this, and most of us are pretty good at treating tibial disease at this point and recanalizing them and really optimizing results. But what about a patient like this who has bad outflow? The last outflow of their leg is compromised. What do you do in these cases? Well, you have to really understand the anatomy if you're going to treat these types of patients. When you think of pedal plantar loop anatomy, I want to point out a significant landmark. When you're looking fluoroscopically, you really want to look between the bases of the first and second metatarsal. When you think of the pedal plantar loop, obviously we're talking about the anterior tibial artery continuing into the dorsalis pedis, and at the base of the first and second metatarsal, that's the first turn into the deep perforating artery, which then comes back to the lateral plantar artery and then back to the posterior tibial artery. So that's your pedal plantar loop. But this first interspace between the bases of the first and second metatarsals is a good fluoroscopic landmark to make note of when you do pedal plantar or pedal interventions. So what's the best way to image the foot vessels? Well, this is a great article from Dr. Manzi and his crew from Radiographics in 2011. And what you can see, it basically looks like a foot x-ray. You're optimizing the II to look at the foot in parallel, and you want to make sure that all the toes are separated and open. And again, you want to look at this first space here between the first and second metatarsal. That is your landmark in terms of where the first turn from the dorsalis pedis to the deep perforating artery is going to happen. And then at the base of the third metatarsal, maybe the fourth, is when you'll get your next turn into the lateral plantar artery to complete the pedal plantar loop like that. So when you're imaging the foot vessels in the lateral view, you really want to get a lateral foot x-ray. And what you're trying to do is you're trying to profile the base of the fifth metatarsal. And you typically, if you draw a line like this, you want this line to intersect the base of the fifth. And the reason for that is because it basically opens up or splays the medial and lateral plantar arteries so that you get a good view or look at the pedal plantar loop. And so that gives you, that helps you optimize your imaging. So what does it look like angiographically? Here's a couple of angiograms from a normal patient who had really no abnormality in their pedal plantar loop. And you can see again at the base of the first and second metatarsal, here's the dorsalis pedis artery making its first turn into the deep perforating artery. And then near the base of the third or the fourth here, it's making its next turn into the lateral plantar artery. And because we have an optimized lateral foot x-ray with the base of the fifth metatarsal down here, as you draw a line through this, at the base of the metatarsals down, you want that to intersect the base of the fifth metatarsal so that it opens up this bifurcation of the common plantar artery. But remember, despite that being a normal angiogram, there are variations, and you have to understand that when you're dealing with pedal below ankle interventions, you're going to be dealing with variations. And most of these vessels are occluded or stenotic, and so things may not look normal. And so sometimes figuring this out is not the easiest thing to do. So what do you do in terms of angiography? This is kind of the way I like to do it. There's obviously different ways. I typically like to get antegrade access. I put a 6 French sheath as distal as possible, ideally in the below knee or segment of the popliteal artery, or maybe even at the knee joint, and really perform a high quality angiogram, including AP and lateral views, because this really allows you to optimize your filling of collaterals and the native blood vessels that are there, allows you to optimally assess cap morphology, collaterals, and distal targets, and it really helps to determine your access sites and treatment. And if you do proper angiography, hopefully you'll achieve angiograms like this. This is a case of mine. You can see I did an AP and lateral foot, and it really shows you kind of what's going on. Here's your lateral plantar artery here that just kind of dies out. So you can see that this gives me an idea that I'm going to have to tackle this posterior tibial common plantar, and then try to complete the loop in the lateral plantar artery. So let's go over some basic concepts when dealing with below ankle interventions. The first thing you have to realize is that you're dealing with CTOs and different types of caps. If you've never seen a CTO, this is what it looks like under a microscope in cross-section. All these little black arrows are really pointing to tiny, tiny microchannels. So that's what you're trying to get through. So you can imagine this really helps you in terms of figuring out, why do people really say, oh, I use an 014 or an 018 guide wire and so forth? Because you're trying to select or get into these tiny microchannels, which are very, very small. When it comes to cap analysis, one thing that's important to look at is what type of cap do you have? Obviously, if you have a cap like this, your guide wire, your catheter initially are going to puncture the apex and you're going to be intraluminal. But where you end up down here really depends on how you do your recanalization. Obviously, if you have a cap that looks more like this, then your catheter or guide wire are going to hit this apex, slide off to the side, and probably become subintimal right away. And again, where you end up here depends on how you do the rest of your recanalization. And obviously, in these types of cases, you may need some type of reentry device, which you would use above the knee, maybe below the knee, but there's really no options for reentry devices below the ankle. The concept of CTOs and hibernating lumen is very important. So remember, when you have a CTO, it's described typically by a proximal cap and a distal cap. And if it has a hibernating lumen, meaning that it's angiographically occult, you do an angiogram, you might see this occlusion, you might see this reconstitution point, but you see nothing in between. And this channel is there, it's open, but it's just angiographically not seen. And it may be filled with debris or a thrombus or chronic fibrotic debris, but it is open. On the other hand, when you have a CTO that has no hibernating lumen, you obviously have a proximal and distal cap, but everything in between is chronically closed. And so this is a much harder recanalization here because you have to fight your way through this entire chronic total occlusion. And here's an example of that. This is a patient, CLI. You can see he has a nice perineal artery with a nice anterior and posterior communicating branch, maybe a stump of a dorsalis pedis here, but nothing really in the foot. So either these are hibernating or they're completely chronically occluded. Well, once I basically got through and got my catheter into the lateral plantar artery, angiography showed that there were really a lot of blood vessels in the foot that weren't seen angiographically. So this is a classic example of hibernating vessels. Another concept that's very important when dealing with below knee, but with below knee and even below ankle interventions is direct versus indirect revascularization. So I like to think of direct revascularization as the angiosome concept. In other words, I'm opening up a vessel that's directly in line with the abnormality that I'm dealing with, versus the angiographosome concept, which means that I'm doing the angiogram and saying, oh, even though there's not a specific blood vessel going to that area, collaterals from another blood vessel that I didn't expect are supplying that territory. And I'm going to show you two examples of those. Here's example one. This is, again, CLI patient, occluded DP, pedal arch doesn't look very good. After pedal loop reconstruction and significant angioplasty, you can see that on the final angiogram, there's robust filling of a lot of things. So I basically opened up the vessel that I knew was causing this problem in the foot to revascularize. So that was a direct revascularization. On the other hand, here's a patient that underwent a TMA and then several weeks later showed up with wound dehiscence, gangrene, and was really at risk for a major amputation. And what she had on angiogram was basically everything occluded from the knee joint down. I was unable to really open up the anterior tibular, posterior tibular arteries because she was a diabetic with CKD. They were heavily diseased and calcified, and I was unable to recanalize those CTOs, especially because they were the entire length of each vessel. But I was able to open up a perineal artery, and you can see on this angiogram here that that perineal artery really gave a lot of indirect flow or collateral flow to really the anterior and posterior circulation of the foot. And so this really allowed for us to get to this point where we have almost complete healing. And hopefully in another few months, we'll have complete healing and prevent her from a major amputation. So that's an example of indirect revascularization. So what's my approach when I'm dealing with below ankle interventions? Well, I like to compartmentalize how I do things in three different categories. First is access. There's obviously different approaches. One of them is you can do an antegrade approach via the anterior tibial artery through the pedal loop and then into the lateral plantar and posterior tibial artery. Another option is to go via the posterior tibial artery into the lateral plantar artery, the pedal loop, and then the AT. There's also pedal access. Don't forget that when you're dealing with below ankle interventions and even tibial interventions, you're going to need some level of pedal access. There's 3 ways you can do this. You can do it ultrasound guided, as in these images over here. And remember, this is a normal posterior tibial artery, but that's not what they typically look like. If you've never seen this before, they typically look like this. They're heavily calcified, they're diseased, chronically scarred down, and sometimes even occluded. There's obviously, you can do a fluoroscopic access, as in this case, you can see there's heavy calcification in the distal anterior tibial artery just above the ankle joint. And we really use fluoro and a needle and guide wire to gain access. And then finally, this is one that is not done as often, but is still a viable option, is contrast guided pedal access. And you can see here, angiogram was done, some level of roadmap or fluorofade is performed, and then the artery is accessed using contrast guidance. But remember that pedal access doesn't have to be just retrograde. It can also be antegrade. If you look at this, this is a diseased pedal loop. Access point is here in an antegrade fashion directly into the dorsalis pedis artery to allow crossing of the disease and the CTO, and then therapy was delivered, and then you end up with a good result. You can also do retrograde access, as in this case, where they punctured basically part of the pedal loop, and then we're able to recanalize a lateral plantar artery and then continue to the posterior tibial artery. And don't forget, as in this slide, which shows that multiple access sites may be needed. Remember, usually when you're dealing with below ankle interventions, we're talking about limb salvage, and you really have to pull out all the stops to try to save that patient from getting a major amputation. Finally, there's also digital access. Here's a patient with CLI, great toe ulcer, 4th and 5th toe amputations. You can see there's nothing below the knee joint. There's really no named vessels below the ankle. I was able to basically attempt from above. I got access into an occluded digital artery here. I also have access into a pedal vessel, and I was able to perform recanalization and ultimately perform angioplasty and obtain inline flow via an anterior tibial artery into the foot. Now, is this going to really prevent this patient from having a major amputation? No, but at least now I'm able to bring this patient back and tackle a posterior tibial artery and maybe that pedal loop at a different time. So let's talk about the next category. Let's talk about crossing. How do we deal with disease below the ankle? Well, it really includes a combination of microchannel navigation, whether it's subintimal or ideally intraluminal, because that has better patency rates. We're obviously going to use various crossing techniques, which I'll describe later, as well as progression to slightly heavier tipped guide wires when you're dealing with these vessels. Because you are dealing with tortuous and small vessels, you really want to understand your catheter and guide wire systems. You can tackle CTOs below the ankle with a single catheter system, such as an 014 or 018 CTO catheter, like a CXI, a Corsair, a Fine Cross. You can have a dual catheter system where you have a Corsair or maybe a 018 or 014 CXI telescoped within a 4 French Navy cross to give you really extra support when you're trying to get through some of these chronic total occlusions. And finally, you can also use a low profile balloon as your catheter so that once you've crossed, you can really perform an immediate angioplasty without having to do several exchanges. Typically, these catheters are advanced proximal to the point of occlusion, either in the DP or the plantar artery, and contrast is injected to really optimize visualization of the potential routes of connection for recanalization. And a lot of the common wires I like to use include really the Command 14 or 18, a Regalia wire, Fielder XTs, some people like Pilot 200s, whatever wire you are comfortable with to really help you facilitate crossing of these tortuous and really fragile vessels. And so that's how you have to think about it when you're choosing your guide wires. So what are the various CTO crossing techniques that we have? Well, these are well described in the cardiology literature, and that's really where a lot of them have originated from. There's the knuckle wire technique, the parallel wire technique. There's obviously cart and reverse cart, and then there's the double balloon technique. On this slide, I'm going to talk about this parallel wire technique. So you have a CTO, you're trying from above, your guide wire immediately goes subintimal, So you leave the guide wire in place to basically plug that hole, and then you use another guide wire to try to recanalize the CTO. When we're talking about the knuckle wire technique, what you're basically doing is that you have a CTO, you have a wire from above, you have a wire from below. They're in two different subintimal planes, and you're basically creating a knuckle or a loop with your guide wire and using that to rotate and disrupt the tissues between these two subintimal planes in order to achieve communication and hopefully cross the CTO. Obviously, many of us use cart and reverse cart. With cart, again, the guide wires are in two separate subintimal planes. You're performing an angioplasty from below, in the case of cart, to really disrupt those tissues that are between these two guide wires in order to then allow the guide wire from above or below to really cross the CTO and achieve interluminal crossing. Reverse cart is the same thing, but the difference is you're putting the balloon from above. And again, you can see an example of that where I have a balloon from above and I'm using a guide wire from below. And after doing repeated angioplasty to hopefully disrupt that tissue between the guide wires, which are located in two separate subintimal planes, I'm able to achieve through and through access. The double balloon technique just means you have a balloon from above, a balloon from below. Again, you're performing angioplasty, as in this case here. Here's one balloon. Here's a second balloon. And then you're hopefully disrupting this tissue that's separating these two guide wires, which then you'll use another guide wire from above or below to really cross and achieve through and through access. So when it comes to treatment, a key concept is proper sizing of your angioplasty balloon. This is a study that was done really dealing with tibial vessels, but really applies to other parts of the body as well, in my opinion, especially when you're dealing with small vessels below the ankle. This is a study performed at the Swiss Cardiovascular Center where they basically did an angiogram of a tibial vessel, performed intervention, in this case angioplasty. They waited 15 minutes, then did another angioplasty, repeated the angiogram, and what they found is that in 97% of patients, there was a compromise or recoil of about 30% within 15 minutes. Think about that. You have a 2 or 3 millimeter vessel, and you're losing 30% of that luminal caliber within 15 minutes. You can see how this really affects patency rate and long-term success of your therapy. So proper sizing of your angioplasty balloons with IVUS or EVUS, extravascular ultrasound, very, very important. So when it comes to treatment, we know that IVUS is very important in evaluating the pedal loop, helping to determine accurate artery sizing for angioplasty. But remember, these vessels have to be at least 1.5 to 2 millimeters or larger, if you're lucky, to really get the IVUS through. Otherwise, your IVUS may get stuck, or you may result in some type of injury to the vessels that you're trying to visualize. Remember, it's important in cases of pedal loop reconstruction to perform angioplasty with one long balloon that traverses really the entire pedal loop up into the AT as well as up into the posterior tibial artery. And you want to perform that angioplasty slowly over and keep it inflated for at least 2 minutes, and sometimes as long as 4 minutes, as this helps reduce the chance for dissections. And here's some data regarding that. People always ask, well, how long should I keep the balloon inflated when I'm doing angioplasty, whether it's below the knee or below the ankle? Well, this was a systematic review and meta-analysis where they looked at all the data. A lot of the studies were weak, to be honest with you, and they admitted that. But what they did show was that prolonged angioplasty for more than a minute was associated with improved post-inflation results. When it comes to treatment, remember, several inflations may be needed. You might think, well, I'll do one prolonged angioplasty for 2 to 4 minutes and then I'm done, but you may need to do that repeatedly several times. And what you're trying to really achieve is a less than 50% diameter stenosis without any flow-limiting dissections. Many CLI operators who are getting started ask me, well, what about vessel prep? Can I use scoring balloons? Can I use atherectomy? And if so, what type of atherectomy? Well, many doctors have used the chocolate balloon by Medtronic. It's a relatively low-profile balloon. It causes really minimal trauma compared to other scoring balloons that are out there. And you typically want a vessel size that's about 2.5 millimeters or larger, because otherwise, if it's smaller than that, the nitinol cage can get stuck And that can cause a lot of problems if you're trying to take it out. You can damage the vessels significantly. And even after you do the angioplasty, it can still get stuck. So you want to be very, very careful when using scoring balloons below the ankle. In terms of atherectomy, I think orbital atherectomy is probably the safest in my opinion. I typically use it at a low speed for areas that are heavily calcified or stenotic. But remember, inexperience can really lead to major complications. And so you don't want to use scoring balloons or atherectomy devices below the ankle unless you have a lot of experience in pedal loop interventions. So here's an example of basically what we talked about. This is a CLI patient who has an occluded distal dorsalis pedis artery. The proximal part of the pedal loop's occluded. We did an antegrade access. And I want to show you what it looks like when you recanalize a pedal loop. Remember, it never looks like the picture on the left. That is a normal person and their pedal loop. If you never have a beautiful roadmap like this, but what you want to use is certain landmarks that I showed you. So if you watch this video on the right, there's your normal pedal loop. I want you to pay attention to the base of the first and second metatarsal. See that prolapsing or bulging right there? That's the tip away that's really where your first turn is. And it fits because, again, it's between the base of the first and second metatarsal. And you can see there you take your turn. And then now when you get to the base of the third metatarsal, maybe the fourth, depending on how oblique you are, you'll see that that's really the second turn from your pedal loop or your deep perforating artery into the lateral plantar artery. And there's your recanalization. If you've never seen it, that's what it looks like. Then obviously, as you can see in the top left, we inject contrast. We show that we're intraluminal. In this case, I performed orbital atherectomy, as you can see here. I'm going around the loop. And then I performed prolonged low pressure angioplasty and was ultimately able to get an optimized angiographic result. So in summary, become an expert of pedal loop and foot anatomy. That is the key to a lot of these interventions. Perform high-quality angiograms, including AP and lateral views of the foot with catheters or sheaths as distal as possible, and consider dual injections via the sheath and maybe via a catheter that's in one of the tibial vessels to really optimize the visualization of caps and collaterals and distal targets, because this will help to really determine your access sites and treatment. Always consider additional or alternative access sites. Pedal access, whether it's antegrade, retrograde, is oftentimes needed with these types of interventions below the ankle. Remember accurate sizing of your angioplasty balloons. You will lose about 1/3 of your mean luminal diameter within 15 minutes. So you want to do slow, long inflations to get to the optimal size, which hopefully you've used IVUS or extravascular ultrasound to determine. And the prolonged inflation of 2 to 4 minutes can really help reduce dissections and optimize luminal gain. Only use IVUS, scoring balloons, and atherectomy below the ankle when you're very experienced with pedal loop interventions, because as you can imagine, inexperience can really lead to major complications and limb loss. So know your limitations and always ask for help.